We now come to Estimates Day. We will start with a motion on the supplementary estimate for the Department for Health and Social Care and the debate on the spending of the Department for Health and Social Care. The debate will be led by Sir Geoffrey Clifton-Brown. Minister to move formally.
I beg to move.
The question is, as on the order paper. Sir Geoffrey Clifton-Brown.
Madam Deputy Speaker, thank you for granting us this opportunity to debate this supplementary estimate, which will be an opportunity for all members of this House to look at the PAC report on health and discuss how the money might be spent in different priorities. So I'm honoured to introduce this debate as Chair of the Public Accounts Committee, the first estimates debate on the supplementary estimate of the Department of Health and Social Care. I made this application jointly with the member for Oxford West and Abingdon, Chair of the Health and Social Care Select Committee, and my right honourable friend, the member for Salisbury and South Wiltshire. The Public Accounts Committee, as members of this House will know, is one of the oldest committees of this House and exists to protect taxpayers' money and ensure that their pound is being used effectively. I think it goes back to about 1867. Unlike other committees, we do not take evidence from government ministers, but we take evidence directly from permanent secretaries and the most senior civil servants and public sector officials. We use the National Audit Office to provide audited accounts and value for money reports, and we produce reports of our own with recommendations to government that they have to formally respond to as part of the Treasury Minute. At this point, Madam Deputy Speaker, I would like to pay tribute to Amanda Pritchard, who has just announced that she will be stepping down as the Chief Executive of NHS England this summer. She has overseen the NHS at a time when it has been under so much pressure post-pandemic, and I wish her well in her future endeavours. I'd also like to congratulate Chris Wormold on his promotion to Cabinet Secretary. However, these vacancies at the head of NHS England and the department provide an opportunity for completely fresh thinking within the NHS. Yes, of course I'll give way to the Chair.
Very briefly, I'm very grateful to him for giving way. May I echo the thanks to Amanda Pritchard for her time at the head of NHS England, and would I also welcome the appointment of Dr Penny Dash as the new Chair of NHS England. He is right to say that this is a really important moment in the future for the National Health Service.
Well, I thank the Chair of the Health and Social Care Committee for those endorsements on these very worthy work that these all individuals do put in the health service. So the Department of Health and Social Care is one of the highest spending departments in the UK, with a total departmental expenditure limit standing at a huge £210.1 billion. And I don't believe anybody believes that the NHS is working at optimal productivity. NHS England is the largest quango with the highest budget in Whitehall. However, when allocating funds, it is also one of the few departments that are making life and death decisions which affect the lives of literally millions of patients and their families. Therefore, I think it does deserve the highest level of scrutiny, which is part of what we're doing today. Before even getting onto the figures, the NAO confirmed that the level of productivity in the NHS has dropped by around 23% since the pandemic. And I simply say that unless this is sorted, any reform that the government announces will be sucked into the black hole of the NHS without getting commensurate value for money or results. I will give way. I don't want to give way to too many people, otherwise the Speaker will reprimand me for taking too long. But of course I'm happy to give way to the Honourable Lady.
Giving way. And on that point specifically, I was at my local hospital, County Hospital in Stafford, just a couple of weeks ago, and I noticed that they were still using paper to make notes, paper notes for patients. And actually, it's one of the biggest barriers into us being able to become more efficient in the NHS is our inability to have effective digital systems. Would he agree with me that the investment that's been announced into the NHS is long overdue in terms of moving ourselves from analogue to digital?
I entirely agree with the Honourable Lady. She's obviously been reading my speech, so if she... the announcement will come later in my speech, and then she'll know exactly what it says. Before even getting on to the figures, the NAO confirmed that the level, as I say, of productivity has dropped by 23%. So I welcome the government's commitment to a 10-year plan for the NHS. We've also repeatedly warned that an ageing and increasingly sick population, the NHS will struggle to cope with an ever-increasing multiple complex demands of our populations. So I'd like to split this speech into three sections about how productivity could be improved in the NHS, funding, and as the Honourable Lady alluded to, technical advancements and a shift into community care. The Department of Social Care's day-to-day spending, RDEL, is set to increase by 10.9 billion, from 187.9 billion to the main estimate as produced today of 198.5 billion. However, the worrying thing about the estimates today is that capital spending is set to decrease by around £1 billion, from 12.5 billion to 11.5 billion, a decrease of 8%. This is worrying, as it shows more and more funds are being redirected from long-term investment, for example in new hospitals, that the previous government had committed to. Yeah. And I welcome the Treasury guidelines that have stopped the practice of redirecting up to £1 billion in the last few years from capital to day-to-day spending, and that will mean that more money should be put into spending in that way. So the NHS estate, as we all know from our constituencies, is in desperate need of investment, and our capital investment programme is running behind schedule. The problems with RAC have only added to the necessity of upgrading our hospitals, and I hope the Minister will listen to this plea. In the latest NAO report on the DHSC, the DHSC annual report and accounts shows that local systems, i.e. ICB and NHS providers, reported a year-end overspend of 1.4 billion. This has nearly doubled from 621 million in 22-23. And this was despite an extra 4.5 billion of additional funding during 23-24, which was to support pay deals for non-medical staff, mitigate any impacts from industrial action, and money to address the costs of new pay arrangements for doctors and dentists. Whilst I do not think it's acceptable, the glacial pace in agreeing priorities and approving final budgets for the local systems. And in November, our committee was shocked to hear that in the last 2 years, those local systems, ICB and others, had not had their financial plans approved by the department until June and May, respectively. That is 3 to 2 months after the beginning of the year end. So how can our poor local systems plan efficiently when these final allocations and guidance are so late? However, if the department's main accounts were finalised much sooner, it would mean that our local systems would be able to have their money allocated in a more timely way, and therefore wastage and inefficient spending would be much less likely to occur. So I welcome the Secretary of State's prognosis that the NHS is far too big and complicated. There should be a shift towards allowing NHS trusts more control of their own budgets, as clarified in the 25-26 priorities and operational planning guidance that was published in January. I believe that by moving more funds directly to NHS trusts and ICBs and local systems will improve accountability and give them a level of flexibility about how their funds should be spent better, rather than just focusing on targets and directives. For example, if they were to run a surplus because they'd run their operations so well, rather than returning this money to Whitehall, they could reinvest it in capital projects that are desperately needed. And this also goes hand in hand with the need to improve productivity. So between 1996 and 2019, the NHS averaged a measly 0.6% year increase in productivity. Since the pandemic, the productivity has now fallen by 23%. And in March 24, the Conservative announcement that the NHS would receive £3.4 billion of capital investment for digital improvements between 25 and 26 and 27-8. This begins to start to address the point the Honourable Lady was mentioning. As part of this investment, NHS England is committed to achieving an ambitious average productivity improvements of 2% through the years 29 to 30. Just a second. However, those digital improvements that presaged by that additional £3.4 billion have not yet been fully actioned. I give way to the Honourable Gentleman.
To give way, and I thank you for his speech and the scrutiny he's giving the NHS, which I think is really, really important. I wonder if he would agree with me that part of the issues we're talking about with productivity, and he reflected on the fact that that has been made worse, since the pandemic, is to do with the mental health of staff, and actually that's something that needs to be looked at. And supporting our NHS professionals to be as productive as they possibly can be includes looking after their health and their mental health as well.
That's exactly right. The NHS employs an enormous number of staff, over 1 million people, I think. And of course, their conditions of work are really important if we are to retain them. And that does mean that their mental health needs close attention where they have got problems. And if the NHS can't help with mental health, who can? So I think the Honourable Gentleman hit on a really important point, actually. One of the reasons that productivity is not improving more is that there are 19% more staff in the NHS, but they're only seeing 14% more patients. At our hearing, the NHS officials stated that this was due to more complex and acute health needs, meaning longer stays in hospital. But I also understand, to the Honourable Gentleman's point, that it was due to staff sicknesses, absences, and the ongoing then workforce industrial action that affected most patients last year, making targets more difficult to meet. And I'm still, I don't know about other honourable members, I'm still getting emails from constituents who have had their appointments and operations cancelled at the last minute due to that industrial action, and they're still waiting for their procedures to be rearranged. So along with staff, technology plays a big role in improving efficiency and productivity. And in 25/6, the Priorities and Operation Planning's guidance that the government stated that the NHS organisation will need to reduce their cost base by at least 1% and achieve 4% improvement in their productivity. Now, I understand that these figures are hard to pin down due to the NHS still negotiating with bodies like the ONS on precisely what the definition of productivity is and how it can be measured. So even if the numbers for productivity are disputed, we've still not seen, and I would say this to the Minister on the front bench today, we've still not seen a plan about how these productivity gains can be achieved, and the committees believe that NHS England have produced unrealistic estimates. So we really need to know what is the department's realistic estimate of what productivity gains can be achieved over the next few years. Without significant productivity gains, the NHS will not substantially reform waiting times and achieve best value for money for the very large amount of money we spend on it. We spend, on average, around 4% increase in real terms each year, when the economy is only growing at 1%, which is completely unsustainable in the long run. If we go back to 2013, the Secretary of State for Health had set a challenge to the NHS to go paperless by 2018. Clearly, as we all know, this has not happened because the NHS is still using fax machines. In a digital age of AI, this lack of modernisation produces a risk to patients and a risk to employees in the NHS. Investing in better technology would help with the government's ambition to shift more care into the community. Community health care can take many forms, from GP surgeries, community hospitals, pharmacies, dentists, social care, and so much more. I fear that when we talk about the NHS budget, we predominantly focus on hospital care, rather than the care that most of our constituents need every day. And indeed, Lord Darcy, in his report that was commissioned by this government last year, said that the NHS budget is not being spent where it should be. Too great a share being spent in hospitals, too little in the community, and productivity is too low. And this is where I'd like to pay tribute to our GPs and all their staff across the country, especially in the North Cotswolds. Our GP surgeries are usually the first point of contact with our NHS. From antenatal services, blood tests, vaccination, and so much more, they offer a number of services that could be termed as preventative care. Now, we as a committee did question NHS officials on their prioritisation of preventing ill health rather than treating it, and avoid much more expensive hospital interventions in the future and a much better patient experience. And their reply was that they had little additional headroom to grow preventative services. Yet the public health grant used by local authorities to commission preventative measures such as health visitors and drug and alcohol services is expected to fall in value next year by 193 million, despite the government's commitment to maintaining it in real terms. I really can't stress enough, Madam Deputy Speaker, how I believe that we should be paying much more attention to prevention rather than cure. It is so important. NHS England said that rather than moving funds, there should be a focus on the role of GPs and how they can advise their patients. Although, according to the Royal Society of General Practitioners, more than 90% of patients' direct experience of the NHS is through primary care and GP practices, but currently less than 10% of that total budget is spent on primary care. I just do think, and I say to the Minister very gently, we're getting our priorities wrong here. So, as a committee, we've recommended that the government should clearly define what counts as health prevention spending within the next 6 months and track that spending annually. ICB should also be given more flexibility as how they can spend their money, which might, for example, include redirecting to more community settings who are closer to patients. It might also include redirecting funds to help manage discharges from hospital. And according to the House of Commons Library, the latest data shows that an average of 12,340 patients per day last year remained in hospital despite being clinically fit to be discharged. And even though there is a slight decrease from last year of 1.2%, I do believe that more can be done to ensure patients who are well enough can leave hospital into the community and be closer to their families. This will require better working between social care and hospitals.
On that point,
I'm happy to give way.
I'm very grateful to the honourable member who's making a very powerful case for reforms and review. The Select Committee this morning, in fact, were looking at this very issue in respect of delayed discharge of medically fit patients. But does he not accept that, in fact, what we need is more integration? Because if only a quarter of those delayed discharges are down to a lack of social care package, many of those patients can't be discharged because they have a primary health care condition which needs to be taken care of, and that therefore it's actually integration and not just social care that needs to be reformed.
So, the honourable member makes an extremely powerful point. I'm coming to the conclusion of my speech, and it is on precisely that point. The social care system is not working in this country. It is a political football that keeps being passed from one government to the other. I understand the government has committed to another review of adult social care, where we won't expect results until at least 2028. For many of our elderly patients, this will be too late. The funding of social care is rising exponentially, and I believe there needs to be more focused and joined-up thinking from both DHSC, NHS England and local authorities on how they can support those that need the help to be discharged from hospital in a timely manner and live in their own home for a longer period than they might otherwise be able to. It should not be a postcode lottery that exists now. In conclusion, with more joined-up thinking between different parts of the NHS, I believe the patient experience could be better. However, without substantial increases in productivity, increase in spending on preventative care and public health, with a better functioning social care system, our NHS will never be able to operate at an optimum level at world-leading standards.
I do want to try to get everybody in, so I'm going to start with an immediate 5-minute time limit. I call Clive Betts.
Thank you, Madam Speaker. It's a pleasure to follow the chair of the Public Accounts Committee. Though we sit on opposite sides of this chamber, we spend most of our time in this place now on the same side of the table in the committee. And I welcome and congratulate him on his appointment and the work that he's doing as chair. The very clear remit from the Secretary of State is move to prevention, a move to community care, a move to digital services. That's what it's laid down as. I think when we had the officials from the Department and NHS England before us, what we said, we thought they were complacent about the NHS finances. I have to say, I thought there was no sense of purpose or long-term strategy to deliver on the Secretary of State's objectives. That was a real worrying thing. And if you look now at the immediate problems, you've got a service where trusts and others can run up deficits and seemingly there's no consequence. Unlike local government, where you have to balance the books, otherwise you go to government for approval to capitalise losses. Doesn't happen in the NHS. So you have the problem in South Yorkshire where Doncaster Hospital runs a loss every year. I'm not blaming the hospital there because they've got an old building that needs massive refurbishment, probably rebuilding completely. They haven't had the resources, but those losses mean they go into the wider ICB system, and then it puts pressure on other hospitals, other trusts, to actually not distribute any surplus they might make to community services where it should go in Sheffield, but actually to fund others' losses. That's no way really to incentivise a proper financial arrangement. Absolutely right on moving towards community services. That's not just to get people out of hospital, it's actually to stop them going into hospital in the first place. And that's what certainly could be done. GPs see 90% of appointments and get 10% of the funding. It clearly is wrong. We've got to switch that. Social care, again, the Health and Social Care Select Committee and the Levelling Up Select Committee, as it then was, did a joint report around 8 years ago now. 22 members of Parliament signed up. You know, we're still here talking about the funding. Now, I think Louise Casey is a great appointment. Louise Casey's got a great get up and go attitude. I'm sure she could be asked to get up and go a bit before 2028 because that's a long time to wait for any response. We should be looking a lot more about moving services out of hospitals. There is a proposal around, and I say around because the NHS doesn't tend to act very quickly, for a diagnostic centre at Crystal Peaks in my constituency. The south east of Sheffield is a long way from the two teaching hospitals, so to put services there like MRI scans and ultrasound scans, X-rays, CT scans, and GPs working with consultants who come to see patients in their clinics in the community would actually save money and provide a better patient service, but it seems to get locked up in the NHS financing about the commissioning and who gets paid what to see who when. Really, we've just got to unravel that and recognise that services can be made to improve significantly. Digitisation, of course, the fax machines are legendary, but the other week I had to change a hospital appointment a couple of times. They're really helpful in changing it. I didn't merely get 3 emails and 3 texts. I actually had 3 letters in the first class stamp on them, all for one appointment. This is just a complete waste of money. Talking to the hospital in Sheffield, they're bringing new IT systems to cover the whole of the hospital operation, but it doesn't link into the GP systems. I mean, this is just a nonsense in this day and age that we can get to that sort of unjoined up thinking. A couple of other issues I could raise. The consultants who's been treating me for the last 7 years, hopefully very successful at this stage, for myeloma, has got an idea that given you have to have so much chemotherapy, which you go through, probably at least 6 different sessions, 2 twice a week, then people have to go into the day ward to get those sessions. All right for some people. They've very helpfully rearranged my timetable to suit me coming down here and going back. For many people, that isn't possible, particularly if they come into a specialist unit many, many miles away. He's developed an idea for home chemotherapy. It works, it's good. Certainly, I'll just give away very briefly to
my deputy, who does an excellent job on the Public Accounts Committee. Before he joined the committee, in the last Parliament, we went to Denmark, and they do precisely what he's just saying. Treat chemotherapy in people's home where they have a history of not reacting to it.
Absolutely, obviously done with the clinician's approval and with the patient's agreement. This idea's been around for 2 years now. It's again lost in the labyrinth of NHS discussions and boards and committees. Come on, let's do it now. It's a good idea. It actually is cheaper and it benefits the patient. So why can't these ideas be got up and moving much more quickly? Public health, absolutely agree with the comments that were made. It's like an afterthought. You know, the grant for public health comes out at least 2, 3, 4 months after the main grants for the NHS and for local government. It's like the money down the back of the sofa that the Treasury finds at the last minute. And over the years, in real terms, it's been cut significantly. Public health in Sheffield do an absolutely great job. They work with the NHS Sheffield Place. They've done some really good work in the north of Sheffield in very deprived communities. communities, increasing and improving community care. That's the sort of initiative we ought to follow and pursue and give the ICB the wherewithal to actually support and engage with it. But equality of treatment is something, just my final point, that we ought to build into our aspirations. In Sheffield, you go from one end of the city to another, and life expectancy changes by 10 years. That's simply not acceptable. Yet when we come to look at child vaccinations, GPs get paid by the number of vaccinations they do, which actually means that those GPs with the easy patients to reach in probably wealthier areas get a lot more money for doing the vaccinations than those who are really struggling to engage with deprived communities. That sort of initiative from the NHS is wrong, and we need to correct it.
Oh, John Glen.
Thank you, Madam Deputy Speaker, and it's a privilege to make a contribution in this important seasonal debate, and I would pay tribute to my friend, the member for North Cotswolds, for bringing this debate to the House, and I would commend him on the work that he's doing, chairing the Public Accounts Committee. And as he set out, there are a number of enduring challenges that the NHS faces. Productivity, the integration of different systems, the challenge of public health, and the enduring issue of social care and how local authorities can actually provide the space for the NHS to deliver some of the outcomes that we all aspire to. Now, I spent some of my time prior to the election in the Treasury, and every fiscal event that I was part of, in whether as a PPS to a Chancellor, as an Economic Secretary or as Chief Secretary, more money was given to the NHS. An attempt was made before every fiscal event to ensure that all the relevant stakeholders made the right positive statements about the new commitments made. And yet, 6 months or 12 months later, there was another pressing financial challenge. And I say that because it is frustrating. We all come to this place to try and find enduring solutions to problems that, you know, are quite complicated. And I wanted to make some observations about the challenges of multiple systems operating effectively in allocating resources. In my own constituency, I met with, and I'm sure we all do, meet with GPs regularly. And I met with Dan Henderson, who's a partner at Salisbury Medical Practice. And he, alongside Anna Morton, who's a practice manager, explained to me the complicated dynamics with their ICB, around our ICB, over how to ensure that the right allocations are made for the actual inputs that they are organising at a GP practice. And it's mind-boggling how difficult that process is of securing the right allocations. And the lack of ability, really, to plan effective systems over 1, 2, 3 years and beyond, because this budget cycle is so sort of overwhelming in terms of managing that health system. And I think we have got to, if we are going to tackle this productivity challenge, we've got to come to terms with those connection points between ICBs, between GPs, between local authorities, and how we actually embed behavioural shifts that give us that productivity lift. The second area I wanted to touch on, which I think, despite the record 200 billion of funding into the NHS, is the problem of public health and coming to terms with how we consume health services as a country. Because it is the case that we can become, where something is free at the point of need, we can become very inefficient in the way that we draw down on that provision. And I really do think we have got to work at pathways of informing and helping our constituents access health systems effectively. Now, we've seen an explosion of mental health challenges in recent years, and the NHS has done a fantastic job of trying to deal with that. But I do think the issue of the variable performance of the NHS across different trusts across the country is something that we should not tolerate. And I do think that one way we can raise productivity is actually expose those variances in performance so that those that are leading the NHS can be accountable for them. Now, for many reasons, those systems will be different. They'll have different demographic pressures. They'll have different challenges due to their capital estate. We have got to get these issues out in the open rather than always thinking that just ploughing more money into our NHS system is going to be the way forward. So I welcome the greater investment once again in the NHS, but I do recognise that we are going to need some radical solutions if we're going to change that productivity story. And we as a house need to unite in finding the right fixes and looking at the best ways of bringing them to fruition across our country.
Danny Beales.
Thank you, Madam Deputy Speaker. When the Labour government came into office last year, the NHS was in a critical state. Its fundamental promise to be there when we need it had been broken. The uplifted funding package is the first step along the road to making good that promise once again. But the pressures facing our health and care system are not over. Our system does need fundamental reform as well as investment. And to achieve the ambitious 4% efficiency targets on which this budget is premised will be challenging and will require change. It is vital that we secure additional capital investment. We saw the previous government continually raid the capital budgets of the NHS to balance the books, leaving long-term productivity issues we face today. I've seen in my own constituency hospital wards closed, unable to do procedures, pharmacy and sexual health services desperate to do more, but without the clinical space to expand. So the £3 billion uplift in the future capital budget is very good news. And can I ask the Minister, when she responds, to outline again that commitment to protect capital budgets and to maximise them to deliver the change that we need to see? Through my work on the Health and Social Care Committee over the last few months, I've heard time and time again, and it's become increasingly apparent, that to achieve the three shifts that the 10-year plan addresses, we will have to bring together health and social care budgets. We will have to change financial flows, and we'll have to align health and social care budget cycles to provide long-term funding settlements for both sectors, and also to fix the front door of our NHS, that is primary care, which I'll address the rest of my comments. It's primary care that is best placed to provide preventative advice that keeps people well, to deliver community-based healthcare that keeps people out of hospital. Yet it's precisely these primary care services, GPs, dentists, pharmacists, optometrists, that face some of the harshest underfunding and neglect over the last 14 years of Conservative mismanagement. The government's new deal for GPs announced last week is a welcome first step in improving primary care provision. But GPs cannot do it alone. Primary care is much more than just general practice, and other components of primary care are still in a state of crisis. Community pharmacies are on the same flat funding contract that expired in late 2024, and that funding model is clearly inadequate. Health Watch has estimated that 400 pharmacies were forced to permanently close in the last 12 months. I recently visited Boots Pharmacy in my constituency and saw the great work they're doing on vaccinations, on health advice and so much more, and they are desperate to expand the range of services they offer. On optometry, having recently met the team at Uxbridge Specsavers, it's clear to me that optometry is much more than just glasses and contact lenses. Through advanced testing, they've recently diagnosed people with a range of conditions such as high blood pressure and even brain tumours. On dentistry, the dental contract is no longer fit for purpose, with many practices no longer delivering NHS appointments, and those that doing so at a financial loss. In Uxbridge and South Ruislip, the majority of practices are now closed to new NHS patients, both adults and children, and this clearly cannot go on. With this in mind, the provision of 700,000 extra urgent dental care appointments on the NHS, announced last month by the new government, is vital and desperately needed action, but clearly more is needed. So can I ask the Minister if the dental budget will continue to be ring-fenced? Will we ensure that, unlike the last government, we will not under-deliver and underspend on the vitally needed dentistry budget? And will she confirm that negotiations for the new dentistry contract will begin in earnest this year to permanently fix the dentistry crisis? The mental health investment standard has been absolutely crucial in protecting mental health spending as part of a vital shift towards mental health, a parity of esteem. As we shift to neighbourhood health, I hope the government could explore how better to track community-based health spending and preventative spending, ideally preventing and growing the share that primary care sees as part of the NHS budget. The task of rebuilding our health estate and our primary care system is an immense challenge. However, it is not insurmountable. Labour has turned around the NHS before, and I'm confident that this government will do it again, creating a genuine community-based health and care system. Thank you.
Gregory Stafford.
Thank you very much, Madam Deputy Speaker. And as a member of the Health and Social Care Select Committee, I know that there are serious challenges facing our health and social care system, particularly in the context of current and future funding. We all know that the NHS is under immense pressure. The population is ageing, and with health needs are becoming more complex, and the effects of the pandemic continue to be felt. If we want a system that works for everyone, we need to address these challenges with smart, strategic and effective solutions. Before I became a Member of Parliament, I worked in healthcare, most recently as part of the NHS Getting It Right First Time programme. This programme focuses on improving patient care by studying what works best, comparing data and making practical changes. Through this work, I saw where the system is bogged down by excessive bureaucracy, poor organisation, feeble productivity improvements, which leads to unacceptable, unwarranted variation in care, problems that waste time and money instead of helping patients. We need to streamline processes, modernise services and focus on patient outcomes rather than bureaucracy. And when the last government was in charge, we increased NHS funding to record levels. In 23-24, the NHS's day-to-day budget was nearly 180 billion, and there is even more being spent in the current budget. But the real question is, where is this extra money going? Despite this additional spending, the NHS England's Chief Financial Officer admitted to the Health and Social Care Select Committee that almost all of this year's 10.6 billion uplift will be consumed by pay settlements, increased national insurance contributions and rising costs of treatments and medicines, meaning very little, or indeed none at all, will be left for improving patient care. The government is pouring billions into the NHS, but without demanding productivity reforms, the money is being absorbed by the system instead of reaching the front line where it's needed the most. In my constituency of Farnham and Bordon, which includes Hazelmere, Liphook and the surrounding villages, we have challenges in ensuring fair access to services across our different areas. In Bordon, rapid housing developments continue, yet healthcare provision has failed to keep pace. While the ICB is pushing ahead with proposals for a new health hub, there are concerns that will not meet the future demands of a growing population. Residents who rely on the Chase Hospital need assurance that new facilities will provide long-term, sustainable care. In Hazelmere, the hospital has made great strides in expanding services, reducing pressure on nearby GP surgeries and major hospitals like the Royal Surrey County Hospital. But ongoing support is needed. Upgrading equipment, increasing staffing and ensuring continued investment will allow Hazelmere Hospital to remain a cornerstone of our local healthcare provision. In Farnham, meanwhile, it faces persistent issues with both healthcare and access to dental services. The shortage of NHS dentists is an escalating crisis, leaving many residents without the care they need. Too many people are forced to travel long distances or go without treatment entirely. And indeed, across the constituency, transport links to places like Frimley Park Hospital remain a concern. As a regional hub, Frimley Park plays a vital role in serving Farnham and beyond. However, for many residents, particularly those in rural areas, accessing this treatment is a challenge. I've worked closely with the local authorities and Frimley Park to improve transport connections, including the expansion of the Waverley Hopper service. But if the government truly wants to expand services, it needs to look at it holistically, not just the buildings, but how patients can access them. Now, Labour's tax increases on GPs, pharmacies, care homes and social care providers are putting vital services at risk. The Royal College of GPs has warned that these changes could force some surgeries to close or reduce their services. In my own constituency, this has been amply demonstrated to me when I visited Badgerswood GP surgery and pharmacy. I've also spoken to Dr Kabir from Hampshire Primary Care Network and Tim Corey from Guardian Angels. They told me that these changes are forcing small healthcare providers to cut staff hours, downsize operations and even lay off employees. Hospices are also struggling, with projected costs increasing of 30 million. I'm lucky that Phyllis Tuckwell Hospice in my constituency is currently going through a major rebuild, but others are not so lucky. The government needs to focus on real reforms that improve productivity and modernise healthcare. If the Health Secretary is serious about making the NHS better, he must explain how he plans to integrate these innovations into his 10-year plan. The reality is that this Labour government has failed to build the new hospital programmes and has cut the government's social care cost. Labour have no plans to fix the NHS. Instead of returning to the futile model of Whitehall knows best, the government we should be looking at actively devolving funding and to local systems with the provision of punishment if they fail. And ultimately, it must have an honest and open conversation with the public about how we deliver, provide and fund healthcare.
Jen Craft.
Thank you, Madam Deputy Speaker. Meeting with my constituents in Thurrock serves as a constant reminder of the state of our NHS and the health of our nation. I regularly hear from residents who cannot access NHS services, being stuck on a waiting list or unable to see their doctor. And I see how the social determinants of health play out, putting people in parts of my constituency at a disadvantage from day one. Housing, unemployment and education drive health inequalities, and in our most deprived communities, people do not live to see their 80th birthday. This is representative of the immense task this government has been set. The funding of the health service and the estimates we are discussing today are fundamental to turning the tide on these trends. 14 years of neglect and failure, the highest waiting lists on record, an ageing population that is getting sicker, and unmet need in the communities across the country mean that the NHS is at a pivotal point in its history. It must fundamentally change how it operates in order to survive. The £22.6 billion of funding committed to revenue spending at the budget was a welcome and much needed cash injection, the impact of which is already being felt, and the delivery of Labour's manifesto commitment of 2 million more appointments a year is testament to this. Waiting lists have fallen for the... I will give way.
I'm grateful for her giving way, and I did mention it in my speech, but I think she was there at the Health and Social Care Committee when the Chief Financial Officer of NHS England said that the 10.6 billion extra that's allocated for this year would be entirely eaten up by other costs, including national insurance rises, and there would almost be no extra money for frontline patient care. Does she remember that?
I thank the honourable member for his intervention. I was indeed at that committee, and I also remember the reflection that the NHS England was incredibly grateful for the amount of money that was being given, which was the highest amount of money given to any department at the budget, and was a significant much more than has been given in previous years. I will continue on. So waiting lists have fallen for the 4th month in a row, which I would hope the honourable member opposite and his colleagues would welcome, with 160,000 fewer people waiting for treatment than when Labour took office, including a member of my own family. So I'm very grateful to see that happen. And extending the opening hours of community diagnostic centres, like the one set to open in my constituency this summer, will be key in catching conditions earlier. So while I welcome these measures, I would like to sound a very, very key point that while funding alone is not enough to change and to save how our NHS operates, we must really turbocharge the left's shift to community healthcare, to neighbourhood healthcare. In my constituency, it's often the front door to the NHS that lets local people down. Quite often, it drives admission to A&E when there is no available alternative. And we have some of the most acute GP shortages in the country, with an average of 3,431 patients per GP. Neighbourhood health hubs promised by the previous government are yet to be delivered. People in Tilbury, one of my most economically deprived areas, are still waiting for a long-promised facility, which currently looks like a hole in the ground. And I would welcome a discussion with the Minister about how we can work to deliver this. The record funding uplift for general practice, with £889 million of investment, is again very welcome news. But it does highlight that there is a fundamental tension between tackling the crisis in acute care and driving the vital left shift to community care that will be fundamental in turning the tide on the NHS. We must not lose sight of the goal of creating a healthier population to reduce pressure on acute services in this country and create better, healthier lives and deliver the right care at the right time that puts a focus on the individual. Thurrock Community Hospital in my constituency delivers excellent integrated community care that brings together social workers from the local authority and NHS staff to meet people where they are at, intervening early and reducing pressures on acute care. This is partly in thanks to a real partnership between the local authority and the Integrated Care Board, and they've removed the need to focus on which public body benefits and which public body pays. But just to point out that we have one of the lowest spends on adult social care in our local authority, in part due to measures such as this. The real focus that they look on is how do they deliver for individual patients? What is it that patients need and how do they get to that place? So I welcome the bold move to drastically reduce the strict targets placed on ICBs in the recent planning guidance, allowing more of this work to potentially take place by giving independence to integrated care boards to make decisions that are relevant to their local population. However, I have heard from ICBs, including my own, that there is a risk that a focus on the elective care target may draw focus and attention away from prevention. And I would particularly like to draw attention to the removal of the learning disability annual health checks from the planning guidance. This is a community that is historically underserved and they have historically undermet health needs. This is a population that dies younger and does not actually access preventative care at the point at which it would be beneficial for them. We know that blanket prevention does not cover populations such as these. They need specific intervention that allows them to access the healthcare they need and when they need it. So while maybe a blanket annual health check is not necessarily the right way forward, it's absolutely critical that groups that are historically overlooked and are not served by our current healthcare system, as well as other groups, are not overlooked going forward when we shift to community work and prevention work. So to conclude, I very much welcome the strong investment that this government is making in our NHS. It's absolutely vital to turn this around and to make sure that this is there for generations to come. But I would like to welcome the Minister's thought on how we incentivise prevention as well as acute care.
Chair of the Select Committee, Layla Moran.
Madam Deputy Speaker, now I think we're proving that the estimates are not dull, much as they have a terrible reputation for being so, because everything comes from the money, and if you don't follow the money, then you don't do our constituents a service. Now, the government has announced an incredibly welcome £22.6 billion increase in the health and social care day-to-day spend, and that's in addition to the further £3 billion in the capital expenditure. And it sounds like, and it is, a huge amount of money. And if it's not spent wisely, the only thing that will be bigger than the uplift itself is the disappointment of our constituents if it doesn't lead to the change that they so desperately want and need. So I'll start by an example. A constituent of mine was referred to her GP for an NHS-funded assessment for autism spectrum disorder. She took tests which all exceeded the threshold, and then she was told that she had to be on a waiting list with an expected wait of 16 to 18 years. Yes, years. She's now 34, with young children, and waiting for an appointment until she's 51 is clearly ridiculous. So we welcome the 3 shifts, the 10-year plan and the long-term thinking, which hopefully will reverse some of these stories, and I know members across the House will have many similar. I was interested that the Secretary of State chose, of the 3, technology as his top pick when I pressed him to pick a favourite at our committee hearing on the 18th of December. In recent correspondence to the committee, which is now up online, the department credited technology with a 0.7% productivity contribution this year alone. I have a concern, though, that we don't have much detail about how exactly they're going to achieve that, and we will be pressing them on that figure. Prevention is also incredibly important, and it always has the danger of being overlooked. But I can assure the Minister, and I know it's her that's responsible for this, that if they don't do it, we will be pressing them to, as I'm sure the electorate will as well, because it is a no-brainer.
Will she give way?
I will, of course.
I thank the chair of the Select Committee for giving way. The fact, though, is if we want prevention, we're going to have to invest in social care. But the current government spending is to literally put almost all of that investment that she's talked about into the NHS rather than the social care. Surely there needs to be a rebalancing.
I thank him very much for his point, because in our committee hearing just this morning, we heard very well that actually all parts of the system now really want to do this. And while acute care trusts recognise that they've got the fair share, actually the bulk of the share, they also realise that unless they start pooling budgets and start doing some of this stuff in a really integrated way, we're not going to achieve the productivity gains that we desperately need.
Will she give way?
I will give way.
I thank you for giving way. And just following on from the previous intervention from the Honourable Gentleman on the Conservative benches, actually the government policies are doing the opposite with respect to social care. Peter runs a small domiciliary service in my constituency, and that is now going bust. 35 people without a job, 100 grand in taxes every year, and all of those patients now blocking beds in hospitals. Does she not agree with me that the government policies at the moment are actually downgrading and trashing social care rather than boosting it up?
I share his expression of frustration that we're not doing more faster, and indeed the very first inquiry our committee has launched is social care, the cost of inaction, because we want to understand there is a cost to doing nothing as well, and that needs to be quantified as best we can. And of those 3 shifts, that shift to the community is incredibly important, not least because successive Secretaries of State have said that they want to do this, and yet the money has flowed in the opposite direction.
Will the Honourable Member give way?
I will, of course.
I thank my Honourable friend for giving way. In Cromer, in my constituency, about 18 months ago, the Conservative-controlled County Council closed down Benjamin Court Reablement Centre. It's exactly the sort of facility we need to help bridge the gap between acute hospitals and the community and primary care. Will she agree with me that we must work to reopen these facilities, and also that they don't stand a chance until proper integration of budgets between the NHS and adult social care providers?
I thank him very much. And where there are examples of where this works well, we should be celebrating them, not shutting them down. In Oxford, the Hospital at Home programme run by Oxford University Hospital Ambulatory Team is doing incredible work. I visited 91 years young Mavis the other day, who in her home was receiving top-notch ultrasounds, better quality than what she could get in the hospital, saving hundreds of pounds to the NHS and no long trip for her and her family who take care of her into hospital. This is definitely something we should be doing more of. But let me turn to the estimates, because this is why we are here. So we've got the supplementary estimates that have been published. I'm not here to hit anyone over the head with them, and they are incredibly heavy, but they are worth a read, because in that supplementary estimate, it talks about £198.5 billion for the day-to-day spending budget. And while on the face value, it's an increase, actually, of £10.9 billion since the estimate in July, 9.2 billion of this is on staff pay increases. Now, let's be clear. They deserve that pay rise. It's long overdue. Retention is important. Mental health is important. We must invest in our workforce. But it does just leave £1.7 billion. I will make some progress if I may. The clock is ticking down. But it's worth saying that after you take that £1.7 billion, you add in NIC's increases, inflationary costs, the NHS has had to ask for an additional £812 million on top. So it is already running a little bit behind. And next year, the increase is due to be £10.6 billion. And as we heard in our hearing, the expected pressures are £11.7 billion. We can all do the maths. There is a problem. And the way it's going to get solved, at least on paper, is an enormous 4% productivity increase, which is a combination of productivity and cost reductions. We need more detail about how exactly that's going to be done. I would like to echo my committee members' point about capital expenditure as well. In these estimates, we see already there has been a decrease in the capital spend by £1 billion from the 24-25 main estimate. The
it's explained away as a transfer of day-to-day spending due to a reclassification of spending on technology and new hospitals as day-to-day spending. Well, I don't know about you, but that doesn't sound quite right to me. And I am concerned that the government is falling into the same traps that previous governments did, perhaps quite understandably, because you've got to pay for the day-to-day somehow. But if the assurance they gave to the Public Accounts Committee was that they would stop doing this, well, I wonder if it is still the case and if it's possible. And very finally, I want to say, well, I want to do more of this. I want to do more scrutiny of the estimates, but actually it's quite hard to do because if you look at the detail of it, there's a lack of detail. For example, there's £120 billion in this document that comes under the subheading of NHS providers with absolutely no detail under that at all. So my ask of the Minister is, would she commit to working with the committee and the House of Commons Scrutiny Unit to provide Parliament with a meaningful breakdown so we can have more wonderful debates just like these?
I am now going to start with an immediate 4-minute time limit. Neil Duncan-Jordan.
Thank you, Madam Deputy Speaker. I want to start by acknowledging the £25 billion additional funding for health and social care allocated in the autumn budget. Already we are beginning to see improvements in waiting times, dental appointments and access to treatment. This is absolutely what my constituents in Poole wanted and needed to see from a Labour government. The area, though, where funding is more challenging, I'm afraid not. The area where the funding is more challenging is around the issue of social care, and that's what I want to focus my comments on. There is widespread acceptance that our current social care system is neither sustainable nor fit for purpose. For far too long, it's been the Cinderella service of the welfare state, overlooked and underfunded, and suffering from a number of inherent problems that started to emerge decades ago, but which have now become critical as a result of severe cuts to funding and increasing demand. Most people who've looked at the system recognise the huge cost to the NHS of keeping people in hospital when they could be discharged into the community, but too often there are not the care packages in place to enable that to happen. This will only be resolved when we have a better understanding of the dynamics of social care and have a more effective way of managing it. Now, part of addressing the crisis in the system therefore requires us to reconsider the meaning of the term social care and to abandon the false divisions between medical, nursing, personal and social care, and instead regard all of these activities as part of a single care service. Now, a new national care service should therefore seek to go further than the existing model of provision, as well as providing free domiciliary and residential care to all existing users who are currently self-funding. It should also have to take account of the 2 million older people who currently have needs that are not being met by the system, improve the terms and conditions of care staff, strengthen regulation and monitoring of services, and provide greater support for the country's 5 million unpaid carers. That's why there needs to be an immediate national debate about a new national care service that can be publicly funded and delivered, and about what it should include and who should be responsible for its delivery. And I'm afraid the new Casey Commission will only delay that debate further, in my view. Now, we have known about the problems for a very long time. Over the last 2 decades, we've had at least 20 commissions, inquiries and reports analysing what is wrong with the system and what might be done to address the problems. However, successive governments have all found the issue too difficult to tackle and instead have favoured short-term answers which have largely left the system untouched. The issue that all politicians have avoided is the false division between health and social care and the question of how that care should be funded. No one should face personal care costs simply because they're unlucky enough to suffer from conditions like dementia. This undermines the very principle of our NHS, so society must share the burden with those most able to contribute, making their fair share. Our universalist principles must take us to talk about correcting these inequalities, ensuring that the wealth, resources and budgets are used to build a fairer, healthier society for all.
Joe Robertson.
Thank you, Madam Deputy Speaker, and I commend my honourable friend, the member for the North Cotswolds, for bringing forward this debate. And I agree with the majority of what I've heard in this chamber so far. We must understand the context of these large figures that are being announced by government, and I turn in particular to the £10 billion for the NHS next year. It sounds like a big figure, but my colleague, the chair of the Health and Social Care Select Committee, has informed us, and she is right, that the vast majority of that money, around 8 to 9 billion, will be taken up in union pay deals, national insurance increases brought about by the Chancellor, and inflation. When all essential costs that the NHS have to meet are taken into account, the £10 billion represents a shortfall, and the NHS will only be able to deliver if it delivers productivity gains. So we must understand £10 billion won't even meet the required costs of the NHS, and of course I give way to my...
I appreciate the honourable member giving way. I would just like to ask the honourable member, does he not consider the workforce a vital part of the NHS, and that funding them properly, recognising them properly through a pay deal that appropriately recognises the effort they put in, is part of the work of turning round the outlook for our NHS?
I agree with all those things, and I'm happy that we agree with each other, and I hope that she will acknowledge that £10 billion does not cover the basic requirements the NHS needs. It delivers nothing more. In fact, it delivers less, and the NHS will only be able to continue to grow if it delivers productivity gains, and it should. Of course I give way.
Does my honourable friend for giving way, does he, like me, remember that when the Secretary of State was in opposition, he was very clear at the time, which said there would be no pay increases unless there were going to be productivity gains and reforms to the way the NHS operates. Now that they're in government, that seems to have completely evaporated.
I remember it very clearly, and what I would like to see the Minister do is spell out how she delivers those productivity gains through reform. We want to hear more detail so that we can be confident that the NHS is secure. And if I now turn to one area she might like to reflect on, that is the use of technology. The candidate to take over as chair of NHS England, Penny Dash, said very clearly at Select Committee that she would like to see technology deliver, and she sees lots of opportunities. But she herself remarked how basic technology in the NHS is not working. And I recall she used the example of nurses taking half an hour to turn on a computer system, having to use 5 passwords to access it. And I said to her, it's hardly sensible trying to deliver technology gains around AI and all those opportunities it might bring if we cannot deal with very, very basic low-tech problems throughout the NHS. And she agreed with me, and she accepted that's a challenge. Now, I would like to see how the Secretary of State, through the Minister, is going to support NHS England deliver that. I would also like to see the dementia target, diagnosis target, brought back into the planning guidance document for NHS England. It was taken out this year. It was taken out with consultation with the Secretary of State, so he allowed that. Diagnosing dementia is the most important thing we can do for people living with dementia and their families. To take that diagnosis rate target out is inexcusable. I accept the wider point that if everything is a target and everything is a priority, then nothing is a priority. But I hope we can all agree that the biggest killer in this country, dementia, must be a priority for the NHS. And that target for diagnosis rates must come back into the planning guidance next year. Indeed, the word dementia doesn't even feature in that guidance, which I think is frankly shameful. And if I finish by talking about where the money gets spent. We can have disagreements about how much is needed, but Lord Darcy was very, very clear. It is not being spent in the right places. Too much money in the NHS is being spent on hospitals and not enough is being spent in the community. So the Secretary of State is going to have to take some tough decisions. He accepts that. One of them is going to have to be to reduce the proportion of money spent on hospitals. That is difficult to do. It's difficult to do politically, but we are prepared to back him across this House if it's part of a plan to deliver meaningful change and to move more people out of the hospitals into communities, which is where they want to be treated most. Nobody wants to be in hospital if they have no medical reason to be there. And finally, the Chancellor must understand that every decision she takes must be coherent and it must be consistent with delivering the 3 shifts. So when she came to this dispatch box to deliver the budget in October, she recognised that national insurance increases were going to be crippling for health care. That's why she exempted the NHS from those increases. But she failed to exempt other key providers of health care, particularly in primary care, like GPs. So it's no good now saying the GP pay deal is a record pay deal, because when you take out the money they've got to pay for national insurance contributions, that represents more than 50% of the money the government's given them. So the Chancellor must back up the left shifts with her fiscal decisions from this dispatch box.
Before I call the next speaker, members may be wanting to know that with the amount of time that we've got left on this debate, the amount of members that were wanting to speak in this debate, I'm not going to be able to get everybody in, even with a 4-minute time limit. I call Josh Fenton-Glynn.
Thank you, Madam Deputy Speaker. I'm pleased to be called on this debate, and it's an important one that we have it. When we talk about the NHS, we can either argue about specific investments or general principles. And like many colleagues, I have received a great amount of correspondence highlighting no end of specific areas where investment is needed. Looking towards my constituency, I could also speak about the need to invest in urgent treatment centres in Bordon, celebrate the work of Calder and Huddersfield NHS Trust, just 2 things that I continue to raise with my honourable friend, the Secretary of State for Health. However, as I have the privilege, among others in this chamber, of sitting on the Health and Social Care Select Committee, I do want to talk in more broad terms of some of the problems facing our health and social care system and about how the proposed shifts in the NHS need a reprioritisation of resources. I'll be focusing on what I argue is the most important of these shifts, the so-called left shift of care from hospitals to the community, something that the member for the North Cotswolds has already outlined the need for very well, although to hear him speak you'd think that it had come from on high and not been the result of 15 years of previous government. With 1 in 10 people stuck on waiting lists in the healthcare system that's becoming increasingly hospital-centric, those lists will only grow if we continue on the same course. And there's no solution to our crisis in emergency medicine without a left shift of solving problems earlier and closer to home. Of course, we need hospitals, we need to invest in them, but they should be where people go with acute and complex cases, not where they go for want of working services elsewhere. But despite the need to shift to care to the community being obvious to just about everyone, one of the most glaring revelations in the Darcy report was just how poorly successive governments have gone about achieving that. Meanwhile, we're not training or retaining enough GPs, and this is where the renegotiations of the contracts are important. In Calder Valley, the retention crisis has meant that Bankfield and Church Lane surgeries, the North Home practice and Rastrick Health Centre all have a ratio of patients to fully qualified GPs that is far higher than the local, regional and national averages which simply don't meet the need for what we need from our health service. And over a decade after the Dilnot report, social care remains a forgotten service, or the Cinderella service, as my honourable friend for Poole artfully called it. With 1.4 million social care staff, our care system is in fact the same size as the NHS workforce, but it receives nothing like the support or understanding of other areas of our healthcare system. The consequence of this is that week after week our committee heard about delayed discharge. 20% of beds in my own local hospital are taken up by people who should be treated at home or closer to home. Meanwhile, carers are missing their appointments because they're delivering care to loved ones and they end up with worse illnesses, adding to the strain on the NHS. Madam Deputy Speaker, in less than a year, this government has ended the industrial action in our NHS, delivered 2 million extra appointments, and is now setting up a new deal with GPs. But that can't be the extent of our actions. Just as the 10-year plan can't continue down the same road as the last government took us, we're trying to fix the crisis in the NHS by putting more money into hospitals. That tackles the symptoms but not the causes. So when setting out the estimates, I urge the Minister to be mindful of the shifts that we need to ensure our funding not only increases, but increases in focus on community and social care. That's what we need for a sustainable system that will protect the rest of our health service in future, because a sustainable system is the only way to deliver better health care and better social care for people across this country.
Seamus Logan.
Thank you, Madam Deputy Speaker. I begin by commending the Right Honourable Member for North Cotswolds in securing this debate today. I also want to pay tribute to the retiring Interim Chief Executive of Grampian NHS, Adam Caldwell, an outstanding public servant who will be sadly missed when he departs from his post. The revised departmental expenditure limit for the Department of Health and Social Care in England sees an overall increase in the estimates, I think, of around 10 billion. And I want to comment on how they affect Scotland generally and my constituency in particular. Now, lest we get giddy in these numbers, let's think about where this expenditure might be going. Salaries and wages, price increases, particularly fuel and food, but certainly more taxes. A new definition of the circular economy, as I understand it. Now, let us also consider how these changes affect our partners in the enterprise of health and social care. GPs, hospices, charities are already facing huge financial pressures from rising energy costs, staff retention issues and labour shortages. Staff morale is already low and will be further impacted by funding cuts in the vital services they provide as money is diverted to meet these rising costs. And then along comes the increases to employer national insurance contributions for these partners. When we look across the border into England, we see additional GP contract funding in England of close to £1 billion, which will cushion much of these additional national insurance costs. Let me share a local example from Aberdeenshire Council, where I was an elected member for more than 2 years. The cost to the Council of the additional NIC changes is about 11 million. The Council's estimated allocation from the Scottish Government to mitigate these additional costs is around 5.5 million. The difference is stark and cannot be simply written off as a Scottish Government responsibility. As West Streeting constantly reminds us, all roads lead to Westminster when it comes to funding. And it is our joint enterprise partners like GPs, third sector organisations like Marie Curie, and I see you all wearing the daffodil today, like Chest, Heart and Stroke Scotland, like local GP surgeries in places like Longhaven and Cruden Bay, who are paying the price. Turning to hospices, the Minister of State, Stephen Kinnock, has stated that there will be no additional Barnett consequentials.
Just remind the honourable gentleman not to refer to people, members by name, by constituency.
Thank you, Madam Deputy Speaker. There will be no additional Barnett consequentials arising for Scotland for hospices. The Scottish Government is investing an additional £4 million in the hospice sector, but that wider sector faces a £2.5 million bill from these additional employer national insurance contributions. A flat exemption would mean that they wouldn't have to pay that cost. Perhaps also not evident from these estimates are the eye-watering costs of agency staff, felt no less in Scotland, partly because of the regressive immigration policies of the last government, now pursued by this government. We've asked for these powers to be devolved to Scotland, and if you can't do that, then there is an alternative approach, and that's been pointed out already by the Right Honourable Member for Salisbury. The Royal College of Radiologists tell us that their workforce shortfalls in radiology and oncology are around 30% in radiology, 15% in oncology. They say the most urgent task facing the NHS is to manage its workforce crisis by investing in an increase of 150 radiology training places and 45 clinical oncology training places. rather than relying on outsourcing and international recruitment. Of course, training costs, and it's every bit as expensive in Scotland as it is here. In conclusion, Madam Deputy Speaker, I say to the Treasury, through the Minister, don't treat Scottish citizens like they live in some vassal state. They are taxpayers too. So rather than expecting us to give you thanks, just get your chequebook out because of the pressures that I have listed. Thank you.
I call Nesil Caliskan.
Thank you very much, Madam. Can I take the opportunity to thank the Chair of the Public Accounts Committee for his work and along other members who I sit on the committee with. The financial sustainability of our National Health Service will have an impact on patients now and in the future. And given it's such a huge amount of money spent by the government, it's imperative that the government focuses on value for money for the taxpayer so that at a time when demand is going up but resources are limited, we can deliver the very best health service that the British people deserve and that my constituents in Barking can rely on. But for too long, the Department and NHS England have taken a short-term approach to budgeting, relying on reallocating capital budgets to cover revenue shortfalls. And between 2014 and 2019, over 44 billion was raided as such from the Department's capital budgets to fund day-to-day spending. As an ex-council leader, this approach has always been curious to me, given that local authorities, as others have mentioned, are simply not permitted to have the same approach. Equally, councils are legally obliged to set annual balanced budgets, and even when they overspend because of demand-led statutory services, we cannot set deficit budgets.
Well, my friend, give way.
Yes.
Another issue that my friend might also wish to reflect on is the fact that the council tax base differs from place to place. So actually councils are even more disadvantaged than the NHS when it comes to funding.
Thanks for his point. It's a really important point because health inequalities are determined by a multitude of factors, and the work that local authorities do on public health is crucial too. Compare the point I made about local authorities not being able to set deficit budgets to the NHS, where every year winter pressures mean that our NHS is at crumbling point and money poured in. Despite the money poured in, the NHS system overspends by last year was £1.4 billion, more than double the previous year. But these issues haven't just emerged in a silo. It's the result, I'm afraid, of years of mismanagement and failed leadership from former ministers and a government that decided to allow the chaos of one-year budget setting that hindered health leaders from being able to effectively plan for the future. It is a lack of political commitment, coupled with a refusal to invest in the future, that has led to awful consequences for patients. And if you take, for example, the NHS estates, we will see that the National Audit Report showed that since 2019, over 5,000 appointments and surgeries and other clinical incidents had to be cancelled due to issues in buildings. It's absolutely shocking. And so I take the points made by members on... I'm not going to take any at this point. I will.
I thank the Honourable Lady for giving way, and it's always a pleasure to serve with her on the Public Accounts Committee under the member for North Cotswolds' leadership. She makes an excellent point about the raiding of capital budgets. In my own constituency, we have a rack-infested hospital, Airedale Hospital, and it is only with a new Labour government, with a properly funded and deliverable plan for new hospitals, that we're going to see that put right. So does she agree with me that the decision by the Chancellor to ring-fence capital funding in the future should mean that this won't be happening again under our watch?
Well, I'm very pleased to have accepted the member's intervention, of course, and I entirely agree with her. But the point is that if you want to see an improvement in the estate of the NHS, you need to have the money allocated to it. And at a time where the NHS really was at breaking point, my constituents had to feel that pain as not being able to get appointments for the sickness that they're experiencing, often in pain. This is a population I represent who already has some of the worst health inequalities in the country, and it's exacerbated by the lack of primary healthcare provision. Some wards in my constituency have no GPs at all. So I welcome remarks made by members on both sides of the House in acknowledging the importance of primary healthcare provision. Without reform, the NHS is simply not financially sustainable. But Madam Deputy Speaker, alongside reform, there must be a culture of change in NHS England. And the Public Accounts Committee report highlights that last year, NHS England failed to approve ICB financial plans until months after the financial year had begun. And working with local NHS bodies, we've seen examples of ICBs, and I know that other members have raised this in their speech too. We've seen examples of ICBs talking the good talk when it comes to prevention and public health. But when it comes down to commissioning, we really, in many areas, see the lack of action in how they commission to have a positive impact on prevention. And yes, I'm happy to give way.
I mean, I entirely agree with the point that she's making, but doesn't the impetus have to come from the top? Unless the government is making strides to shift monies from healthcare to social care, then why on earth should any of the ICBs follow suit?
Thank you very much. And I don't disagree with that, which is why I think the commitment from the government around reform will be so critical. And I sit on the Public Accounts Committee, a report which highlighted some of these gaps, and we will, as a committee, looking very closely at the reforms that will come forward from the government. And I welcome what will be comments from the Minister, I'm sure, and further reassurance on that. The government is absolutely right to be investing into the NHS to help deal with the critical waiting list at the moment, but only alongside reform would the additional investment in the NHS be value for money. And only through reform can the NHS improve productivity to make it sustainable. And I do endorse comments made by members on both sides of the House around productivity, because as it stands, without reform, the NHS cannot even meet its own productivity percentages that they set out. That's why the estimates are so important, as we're discussing today. The 4.9 increase in investment, as I've said, is welcome because it will help cover the pay review body's recommendations, pay increase for NHS staff, stopping strikes, improving staff retention, and keeping more doctors and nurses at work. Absolutely crucial if we want a properly functioning NHS. Madam Deputy Speaker, the Secretary of State for Health and ministers in his team have said time and time again that the NHS is beaten but not broken. These estimates are important because they set the foundation and springboard for what is required to fix our NHS. Thank you.
Call Sarah Bool.
Thank you, Madam Deputy Speaker. The government came into office making all the right noises about tackling waiting lists and delivering a better healthcare service, all things that our constituents want to see. However, since their election, I'm concerned that ministers are giving out more money, about £22.6 billion for the day-to-day running, to the NHS, but without plans for how this may be spent to reform our health service, make it more efficient, and support priority areas like dentistry, general practice, or hospice care. The government is seemingly giving with one hand but taking with the other. No one should underestimate the impact of the increase of the employer's national insurance contributions on our GP surgeries. Both Toaster and Brackley Medical Centres in my constituency have said that this increase would cost at least £40,000 to £50,000 and may result in redundancies and stopping the growth of their practices. Our surgeries are not here to make profits, but to deliver care, and attacks like this make care unsustainable. This is at a time when the Darcy report said that the NHS budget is not being spent where it should be. Too great a share is being spent in hospitals, too little in the community, and productivity is too low.
Will she give way on that point?
Of course.
I mean, I thank her for giving way, and I once again agree entirely with what she's saying. But has she seen anything from this government that suggests that there is going to be a significant shift from acute care in hospital to community care, despite the rhetoric that we've heard from the other benches?
I thank my honourable friend for his intervention, and I do concur. I haven't seen anything, which is why it's so important we have this sort of debate today. Indeed, my GPs are actually telling me on this point that more attention does need to be given to GP practices. These are the Praetorian Guard who can ultimately protect the NHS. Access to timely appointments is crucial, as is rebuilding the key relationships and contact between a GP and their patient. Of course.
Under the last government, we had 20% of NHS doctors thinking about moving overseas. Surely solving the GP contract is a first step to keeping GPs working in this country.
I thank my honourable friend for that, and indeed, and I want to encourage all our GPs to be remaining within the UK and giving back to what they do. So everything that we can do in that regard, I'm always fully supportive of. But also on this, I'll make some progress if you don't mind. Also on this point, this is also reinforced by the Committee of the Public Accounts report on the NHS financial stability from January this year, which concluded that a reallocation of funds was needed to focus attention from sickness to prevention. Now, I am a massive advocate of prevention. Many members will know that I talk about being a type 1 diabetic, and if a member hasn't heard me talking about it, they may have heard one of my sensors going off for a low blood sugar. But there is so much that we could do in preventative measures in the treatment of diabetes. These treatments can be expensive as an initial outlay, but they will solve so many long-term problems. We cannot prevent type 1 diabetes, but, for example, we could have earlier testing in children so that we could avoid them being diagnosed when in a state of diabetic ketoacidosis, which can be fatal. Families can be prepared and ready and avoid hospitalisation, therefore saving costs to the NHS whilst also saving lives. We can also ensure access to technology which can avoid the huge complications. Poor blood sugar control can result in loss of eyesight and limbs alongside heart and other conditions. Making continuous glucose monitors and even insulin pumps available across the country can significantly help the patient and, again, in the long term, save the NHS money. And at the moment, it is a very unfair postcode lottery. So I ask the ministers to consider ways to tip the funding balance to ensure that both prevention and community care measures are funded properly. And a final point. Any reforms to the NHS must consider the computer operating systems in place. Many of my constituents have to go out of the constituency for their hospital care, be that to Northampton, to the John Radcliffe, Horton, Milton Keynes or Kettering hospitals. But all those trusts operate on different systems, meaning that my constituents often cannot have their scans or medical notes shared easily. This is frustrating for residents, but also potentially fatal. One resident noted that his wife was nearly given a drug that she was allergic to because her notes had not been able to be shared correctly, and it was only his presence that saved her. We must ensure that money is spent to look at this and change the systems, and that has been explained by the member for the North Cotswolds very conclusively. We owe it to our constituents, Madam Deputy Speaker, to work across the House to better our healthcare and support the fantastic work of our doctors and nurses.
I will be starting front bench contributions at 3:15, so the final contribution from the back bench is Alex McIntyre.
Thank you, Madam Deputy Speaker. Prior to entering this House, I was incredibly proud to represent our NHS and other healthcare providers in my last career, and I'll continue to fight for our NHS now that I sit here as an MP. And I saw firsthand the impact of Tory mismanagement had on our NHS. Their mismanagement breached one of the fundamental principles of medical ethics: first, do no harm. And this week I saw that firsthand in my own constituency in Gloucester when I visited Gloucestershire Royal Hospital, and I met with Gloucestershire ICB this morning, and earlier this year visited the Tuffley surgery. The challenges they're facing won't be surprise anyone in this House. They were set out in stark terms in the Darcy report. And the challenges we face are replicated across the country in many constituencies: maintenance backlogs, lengthy ambulance waiting times, recruitment challenges, and ageing and more sick population. But what struck me most about my visits this week was the resilience of our NHS staff. Staff committed to people in our county and at my city of Gloucester. And what a difference a Labour government is making with more investment in our NHS. Waiting lists locally are already coming down. Patients are now able to access emergency dental treatment rather than pulling their teeth out at home. We've got more midwives, more dentists, and a new GP contract which will help bring back the family doctor. That is what we can do in 8 months. Imagine the impact we could have if we had 14 years like the party opposite did. And from a personal perspective, I've seen how important this work is. Now, I used to joke on the doorstep that I should be a poster boy for why prevention is better than cure. It won't surprise members that I maybe have a few extra pounds that I could afford to lose. But sadly, the prevention piece came too late for me, and I was diagnosed with type 2 diabetes earlier this year. And I must say the treatment I've received since then has been phenomenal. I'm now on the Pathway to Remission programme that is available in Gloucestershire but not across the country, that has already brought my blood sugar levels down and helped me to lose 3.5 stone, I might add. Thank you very much. And, will help countless others across Gloucestershire and across the country. And it's so important that as we move to prevention work, we also look at public health measures around diabetes, and I echo the comments made by the previous speaker from the opposite benches. And I'd also like to thank all of the staff who looked after my little boy last year when he was really sick, but make sure that when we are looking at investment in our NHS, we prioritise maternity services and those for the youngest in our society to make sure that they get the healthcare that they need. Now, we've talked about British values a lot over the last few months in this place. And when people ask me about what makes me proud to be British, I point them to our NHS, a system without comparison in the world, which means that everyone can access healthcare regardless of their wealth. Now, I know they're not in their places today, but when reforms say that all options are on the table, I'd like the Minister to make clear in her remarks that standing against our NHS and the principles of our NHS being there for everyone, regardless of their wealth, is the opposite of being patriotic, and that their options are not on the table. So, in conclusion, I welcome the record investment in our NHS. I welcome the shift from analogue to digital and from cure to prevention. And I welcome what the Minister can say in her remarks about how we can make sure that we are delivering on the people's priorities in Gloucester.
I call the Liberal Democrat spokesperson Helen Morgan.
Thank you very much. Thank you very much, Madam Deputy Speaker. And I'd also like to start by thanking the Chair of the Public Accounts Committee for bringing this debate and indeed for his excellent opening speech. We all know that we've reached a crisis point across the NHS and care sectors, with more patients than ever waiting for treatment, and it's not just affecting those who are in need of care and treatment, but also those who work tirelessly across the NHS and care sectors who are feeling the full brunt of the crisis. The Conservatives' legacy of hours-long waits for ambulances, treatment in crammed hospital corridors, captured in horrifying detail by the Dispatch's documentary which looked into the hospital that serves my North Shropshire constituents, and communities grinding to a halt under the weight of all sorts of different waiting lists and backlogs. We need urgently to move forward. Now, the Secretary of State has repeatedly outlined the need to shift from treatment to prevention and from hospital to community. And Liberal Democrats absolutely support him in that endeavour. And indeed, we called for many measures that would achieve that shift in our own manifesto. Stronger primary care, stronger community services were the strong recommendations of Lord Darcy's report, which had been commissioned by the Secretary of State and have been broadly welcomed. And indeed, there's been a great deal of consensus across the House today that we need to take those measures. But I fear that these estimates paint a picture of an NHS which is continuing to pour money into the previous failing model, where capital budgets are drained to pay for day-to-day services, where a huge proportion of increased spending goes on NHS staffing, while community care providers and primary care providers wrestle with a huge employers' NIC increase. Combined with the decision to scrap targets on mental health and community services for the sake of prioritising targets on elective care, we must ask the question, when will the stated objectives of the Secretary of State really be matched by actions? These latest estimates are an indictment of the broken state of the NHS after years of Conservative neglect, but we will urge the Government to go further and faster to address the failure. I will give way.
May I share with her my confusion, having heard both her comments and comments made by the benches opposite, that she seems so surprised that she hasn't heard the full solution of what this government is going to do with the NHS, when it's quite clear that there's going to be a shift of 3 shifts and a 10-year plan and a huge amount of reform coming down the line. Has this, as it seems to have escaped the opposition's attention, also escaped her attention?
Well, I thank you for his intervention, but clearly there is a point in the debate at which we need to urge the Government to go further and faster, and as a constructive opposition, that's exactly what we'll be doing. Now, primary care providers are currently on their knees, made worse, I'm afraid to say, by the national insurance hike announced in the budget. They can't meet demand for local appointments, even as things stand. And in many cases, the constraining factor is the estate that they're operating in. So Prescott Surgery in Baschurch in North Shropshire wants to provide additional services to the community. They want to keep people away from hospital, but their surgery is physically not big enough. A local developer has provided land for a new surgery. The local council has still funding for that building, but it can't be done because the ICB won't pay the notional rent, which everybody has agreed to forfeit. It's crazy, and I hope the Minister can commit to finding some kind of easy solution for that kind of nonsensical situation that we find ourselves in. I will give way.
Thank you very much for giving way. And just on that very point about the ICB's inability sometimes to get things going, in my own constituency, it's taken them 9 months to procure a very similar example. Does she agree with me? It's not just about their ability to pay, but also their processes around procurement too.
I fundamentally agree with her. I mean, there are lots of instances, and I just chose that one because I spoke to the providers there very recently. But I want to come on to community pharmacy because I'm particularly concerned about pharmacies at the moment. Pharmacies are a key pillar of care in the community, dispensing, obviously, prescriptions, providing over-the-counter medicines and advice, and they're also critically providing pharmacy first. But they are closing at an alarming rate. Analysis by the National Pharmacy Association predicts another 1,000 will close, 900 of them by the end of 2027, if the current rate of closures continues. And that's because of a 40% real terms cut in their funding since 2015. In fact, community pharmacies are essentially subsidising the NHS by making a loss on many of the prescription drugs that they dispense. And they're going to be clobbered in a few weeks' time in April, not only by the NIC hike, but by the increase in business rates that's going to affect high street retailers. Shamefully, they've not even had their funding rates for the current financial year confirmed, the one that ends in 3 weeks' time. And Pharmacy First, the flagship plan to move care into the community, has not had its funding confirmed beyond the first week of April this year, in just a few weeks' time, according to the National Pharmacy Association. So will the Minister confirm in her closing remarks what is the future of Pharmacy First? Is there a funded plan to deliver that service? And what steps are being taken to keep our community pharmacies in business? Because if we want to see care in the community, it's essential that we support them. I just also want to mention dentistry. In Shropshire, Telford and Wrekin, the number of NHS dentists in 2023 to 24 had fallen by 12.3% since 2019 to 20. Many of my constituents can't access a dentist, and the government has committed to improving this situation. So can the Minister confirm when the negotiations for the new dental contract will be beginning? Now let's move on to social care. The crisis that currently faces the social care system is very daunting, not least because of the additional national insurance hike that will be starting in a couple of weeks' time. Last week, caring organisations launched an unprecedented day of action with thousands of people marching on Westminster to highlight the precarious state of the organisations that provide care. The Darcy review found that people waiting to access social care account for 13% of NHS hospital beds. So we all understand the urgency of tackling social care. But the cross-party talks, which collapsed last week, haven't started. There's no date for a new meeting. There's no published terms of reference. And we think that 2028 is far too late to resolve this problem. So can the government urgently reinstate the talks and act now to deal with this social care crisis? Before I conclude, I just want to talk about mental health. Lord Darcy said there's a fundamental problem in the distribution of resources between mental health and physical health. Mental health accounts for more than 20% of the disease burden, but less than 10% of NHS expenditure. This is not new, but the combination of chronic underspending with low productivity results in a treatment gap that affects nearly every family and all communities across the country. And he's dead right. By April 2024, about 1 million people were on the waiting list for NHS mental health services, of which 340,000 were children. My casework is full of children who wait months and months for the diagnosis and treatment that they need. The government's removed the targets for mental health waiting lists, and I really want to urge them to reinstate them so that we have parity between mental health and physical health in our health service. So, Madam Deputy Speaker, I'm very conscious of time. So, in conclusion, can I just recall our asks to ensure that social care talks start immediately, to deal with this problem with pharmacy, and to make sure that mental health and social care are dealt with equal parity. Thank you.
Shadow Minister Dr Caroline Johnson.
Thank you, Madam Deputy Speaker. I would draw honourable members' attention to my register of interests as I'm a consultant paediatrician. And I'd like to congratulate my right friend, the member for the Cotswolds, for securing this important debate on the finances of the NHS. Madam Deputy Speaker, Labour said they had a plan. They said they had a plan to reform and improve our NHS. Unfortunately, it has become clear with a series of consultations on the NHS plan, the 10-year plan, patient safety review, consultations on leading the NHS, and the Independent Commission to Transform Social Care, to name just a few that are in progress, that they didn't have a plan other than to get into power and then consider what their plan should be. As my honourable friend, the member for North Cotswolds, said, we need improvements in productivity, technology and long-term investments. I completely agree. And I could, as a medic, give many examples of wasteful spending, especially in relation to paperwork and increasingly inflexible guidance and procedures that are well-meaning but often unhelpful. There is general talk of productivity improvement from the government benches, but little specific. I'd be grateful if the Minister could provide any specifics in her closing remarks. But let's see what they said and done so far. At the autumn budget, the Chancellor announced that overall NHS funding will be increased by £22.6 billion over 2 years. And for this year, that's £10.6 billion. The Government is asking us to welcome this extra money. It sounds great, but is it extra or not? Julian Kelly, NHS England's Chief Financial Officer, told the Health and Social Care Committee that the proposed 2.8% pay rise for 25-26 would cost £3.8 billion. The next pressure is worth around £1.7 billion, £1.9 billion in non-pay inflation, and in addition to this, £0.8 billion for GP settlement, as well as £3.5 billion for basic demand growth in the NHS. Vulnerable and right honourable members will note that this figure adds up to more than £10.6 billion. And with unions having threatened to strike again for even greater pay awards, and Labour's propensity to capitulate to the unions, it's quite likely this figure might increase. So can the Minister confirm, will this £10.6 billion that they talk of really lead to an improvement in services, or will it merely cover inflation, tax rises and pay rises given by the Labour government to their union paymasters? And in a moment, let's look further first at those tax rises. It is clear that the Chancellor had not properly considered the effects of the NIC's rise on the wider healthcare system. For example, the Government has exempted the NHS from the tax rise, but this exemption does not cover general practice, hospices, charities, many social care providers, including many care homes, air ambulance charities, dental clinics, opticians, private healthcare providers, agency staff, local pharmacies, and other suppliers and contractors, to name but a few. And let's see what some of them have had to say about the implications of Labour's taxes on their constituents' healthcare. I will give way.
The Shadow Minister for giving way. And I'm sure she's about to come on to this in her speech, but given she's just criticised this government for lacking a plan that is about to come forward to this House later this year, surely she will now put forward her plan on how much extra the Conservatives would propose to put forward for the NHS, how they would pay for that, and why they didn't do that for the last 14 years.
The honourable gentleman looks back at the figures, he'll see there's been a substantial real terms increase in NHS funding over the last 14 years, something that cannot be said potentially for this year, and that's why I'm asking the question. I will give way, yes.
Perhaps I ask the Shadow Minister an easier question then. She's just rejected the pay deals that this government has agreed to give a proper reward to our nurses and doctors. How much do you think that pay deal should be reduced to bring it in line with her policy? So clearly, if she's opposed to the deal that's been agreed, she must have an alternative in mind.
One of the key things about the government's deal is they've given in on money without asking for anything in return in terms of productivity. What the government needed to do was agree a pay deal that was sensible, affordable, and not talk about money that they are giving to the NHS while taking, with the other hand, away in taxes. So let's see what some of the healthcare providers have had to say about the implications for the NICs on constituents' healthcare. The Royal College of GPs has warned that the NICs increase will force GP practice to choose between redundancies and closure. The hospice sector believes that the cost of national insurance rises could be £30 million a year. The government has given the hospice sector a capital grant worth £100 million, which is welcome and will improve facilities. But if these facilities are empty and cannot be staffed, they will not deliver much in the way of improvement. Air ambulances are also under threat from the Chancellor's rise in national insurance and taxes in the autumn budget last year. With the local service in my constituency, Lincolnshire and Nottinghamshire Air Ambulance, which is entirely charitably funded, needing to find another £70,000 just to pay the national insurance rises. The Independent Pharmacies Association estimate that the rise in employer national insurance contributions and minimum wage rises will cost over £12,000 for an average pharmacy per year, totalling more than £125 million for the sector as a whole. The chairman of the National Pharmacy Association, Nick Kay, warned pharmacies face a financial cliff edge at the beginning of April, with a triple whammy of rising national insurance, national living wage and business rates all arriving at once. What impact will this have on our constituents' health? The government talk a good talk about bringing healthcare closer to the community, but actions speak louder than words, and putting extra pressure on community-delivered services is not a good way of delivering their aims. The national insurance rise alone suggests the Nuffield Trust will add a £900 million burden to the adult social care sector, With other new costs factored in, the care sector is believed to be facing an additional £2.8 billion bill. This dwarfs the £600 million extra allocated to the local authorities responsible for providing the social care. This will have a devastating knock-on effect, Madam Deputy Speaker. The amount of care that can be bought by local authorities will fall. The cost of private care will rise, so more people will be reliant on the state rather than the private sector. The very waiting list that the government claims to prioritise will also rise. Many small care providers, the Nuffield Trust warns, will either have to increase prices, stop accepting counsel from patients, or go bust. And this will have a knock-on effect on the hospital sector, as people are unable to be discharged. There is not adequate social care for them. The government talks about creating a new national care service, but it's only managed to damage the existing one by hiking the costs borne by care homes through national insurance rises and other tax and wage increases. In January, the government announced a deal with private hospitals in an attempt to cut waiting lists. This deal, which sounded good to start with, would see private hospitals being paid for each patient they treated, incentivising them to treat as many people as possible. However, the Times reported that NHS England has recently capped the amount that each hospital can be paid, with the Chief Executive of Independent Healthcare Providers Network warning that this policy will actually lengthen waiting times. Can the Minister comment on that, please? Also, another question on prevention. The Minister's focused on prevention. But when the government announced it would be cutting the ODA budget by 40%, the Prime Minister said the UK would continue to play a key humanitarian role in a range of issues such as global health and challenges like vaccination. I'd appreciate clarification from the Minister as to whether the global health budget will be cut or whether the cuts will be made from the ODR budget in other respects entirely. Workforce is the key asset of the NHS. Yet sickness levels are running around about 5.5%, which is a considerable cost to government and a considerable drag on productivity. They do vary considerably across trusts and across professions, with less than 2% consistently of consultants off sick, but almost 8% of ambulance support staff. If these rates could be reduced, it would lead to improved productivity and treatments being treated much faster. So can I ask the Minister what she is doing to look at, perhaps she would have another one of her reviews? Of course.
Has been frequently quick to criticise NHS pay rises. Does she think that there will be more or less sickness absences in the ambulance services if they're better or worse paid?
Is the Honourable Gentleman suggesting that whether someone becomes ill or not is entirely dependent on whether they get another 2% in their pay packet? I'm not sure it is. But, Mr Speaker, the government promised a great deal when they came into power last July. Since then, they have handed out inflation-busting pay rise, raised costs and abandoned election pledges. At the centre of the government's approach is a classic socialist trick, a sleight of hand, taking money away from NHS providers with one hand in taxes and then expecting praise when they've given some of it back with another. The public will see straight through it.
Call Minister Ashley Dalton.
Thank you, Madam Deputy Speaker. I'd like to begin by thanking the Chair of the Public Accounts Committee, the Honourable Member for North Cotswolds, for bringing this debate. And as a Public Accounts Committee alumni myself, it is my pleasure that my first outing at a debate at the dispatch box is in response to that committee. I'd also like to thank all other colleagues for taking part. The number of honourable and right honourable members that have sought to speak today speaks to the significant interest in our health and social care services, not only in this House, but in the country. And the wide range of issues raised just goes to show how broad and overarching our NHS and social care services are. I will try to cover as many of the issues as I possibly can, and if I miss anything, I will happily pick up with honourable members afterwards. I will also attempt to cover all honourable members that have spoken, if I can find a bit of paper that I've written it on. There we go. But again, if I if I miss you, then please do forgive me. Because we've had so many contributions. The Chair of the Public Accounts Committee, the Honourable Member for St Ives, the Member for Poole, the Honourable Member for Sheffield and South East, and many other members have talked about social care. One of the key lines that's come through today has been productivity from the Chair of the Public Accounts Committee, the Honourable Member for Salisbury, for Farnham and Bordon, and for Barking. And prevention and public health has really come through, something that, as the Minister responsible for those areas, I'm delighted to discuss, again raised by many members. We've also talked about dentistry, particularly the Honourable Member for Uxbridge and South Ruislip. The shifts have been really key, and they have been raised by many honourable members today. And the Honourable Member for Barking talked not only just about public health and the work, but also the work of local government and the role of ICBs. I would also like to say that how great it was to hear my honourable friend, the Member for Gloucester, talk about his pride for the NHS, and to confirm that I can commit that this government will always stand by our NHS and will always keep it free at the point of use. Mr. Speaker, Madam Deputy Speaker, in her autumn budget, the Chancellor took the necessary decisions to put our NHS on the road to recovery, with more than £22.5 billion increase in day-to-day health spending and over £3 billion more in the capital budget over this year and next. And thanks to her, we are taking the first steps towards fixing the foundations of our NHS and making it fit for the future. And I say to the Shadow Minister that yes, this will make a difference, because it's not just about the money, it's about making the right choices. I will very briefly, because we are very...
I thank the Minister and welcome her to her place. This has been the fundamental point, I think, from this side. We all accept that we want to see a shift from acute hospital provision through to social care. But when the budget doesn't reflect that the Chancellor brought forward, and the national insurance rises hit the social care end of the spectrum, how can the public have faith that what she says is anything more than rhetoric?
Absolutely. I thank the Honourable Member for that intervention, and I'm coming to all of that. So, since coming into office, the government has made choices. We have ended the resident doctor strike. We've published our elective reform plan that will cut maximum waiting times from 18 months today to 18 weeks by the end of this Parliament. Investment and reform in general practice to fix the front door to the NHS and bring back the family doctor. We've started getting waiting lists falling, and we've kept the promise in our manifesto to deliver an extra 2 million appointments in our first year. We've actually smashed that target in the first 7 months. Madam Deputy Speaker, anyone who thinks the Chancellor was wrong to make the necessary decisions and trade-offs she did must explain what they would cut from that list. Because anyone who thinks they could have achieved everything we've done in less than a year without the autumn budget is frankly living in cloud cuckoo land. Today we are setting our supplementary estimates to the House. The funding will support the NHS to deliver 40,000 extra elective appointments a week and make progress on reducing the number of patients that wait longer than 18 weeks from referral to consultant-led treatment. I can also update the House that we will publish our departmental budgets for the next financial year in the spring through phase 2 of the spending review. And I will very briefly.
For giving way. On page 53 of the estimates, she'll note the decrease of the capital spending by £1 billion in the departmental accounts. Will that be explained? And could she explain to the House how are new hospitals day-to-day spending?
I will be coming to that. I thank the Honourable Member for her contribution. We have talked about productivity, and this was raised by many members, including the Chair of the Public Accounts Committee. Now, several members have raised this, and I'm absolutely delighted that members across the House, including those on the benches opposite, in raising the issue of productivity, have now recognised and accepted the value of the Darcy report that was commissioned by this government. We are committed I will in 1 minute. We are committed to a 2% productivity target by 25-26. To help achieve this target, there's a £2 billion investment in NHS technology, and it's allocated to freeing up staff time, ensuring trusts adopt electronic patient records. We've heard a lot today about old-fashioned paper, and enhancing cybersecurity measures, improving patient access to services via the NHS app. The current measures of health productivity data don't capture all the outputs and outcomes adequately. And to address the accuracy and productivity measures, NHS England is working with the ONS and the University of York to refine those metrics. And reform is at the very heart of our 10-year plan. In terms of capital funding, Madam Deputy Speaker, we're rebuilding our capital-starved NHS through £1.6 billion of national capital funding in 25-26, and that's going to help achieve constitutional standards. The money will help deliver more than 30,000 additional procedures, over 1.25 million diagnostic tests as they come online through investment in new surgical hubs and diagnostic scanners, new beds across the estate, and 70 million to invest in new radiotherapy machines to improve cancer treatment. We have heard about questions around the capital shift to revenue, and has already been identified. Some of that has been a historic need, including capital funding that was identified for technology and new hospitals programmes, but because of the nature of funding, needed to be defined as revenue. It is still being spent on those programmes. The autumn budget made a commitment to ban shifting from capital to revenue, and I can confirm that no shifts of that nature have taken place since the autumn budget. I will give way.
Most grateful to my friend for giving way and not to a member opposite, splendid though they are. I was probably my honourable friend shared with me when the last government put no money into the national new hospital programme, threw out Charing Cross Hospital in my constituency from the programme. She probably shared my great disappointment. So may I share with her my delight that the government has put Charing Cross back into the programme and is funding the programme, and with a timetable that the last government failed to deliver.
I thank my honourable friend for that intervention, and I think, Madam Deputy Speaker, everyone knows the previous government's promise of 40 new hospitals was a fiction. There weren't 40, they weren't new, and many of them weren't even hospitals, but we have put the programme on a firm footing with sustainable funding, so all of those projects will actually be delivered. The chair of the Select Committee, the Health and Social Care Select Committee, my honourable friend, the MP for Bristol South, I am more than happy to work with the committee to clarify the funding on NHS providers. And I understand that there's already quite a lot of information in the public domain, and I'm more than happy to have that conversation with her. In terms of financial levers and incentivising prevention, the 10-year health plan is really the driver of all of our shifts, from analogue to digital, from hospital to community, and from sickness to prevention. The 10-year health plan will set out how we achieve the transformational change. And as part of this, the plan's working groups are looking at how payment mechanisms, funding flows and contracting will need to change to build a health system fit for the future. In terms of ENICs, Madam Deputy Speaker, we've been here before. The government will provide support to departments for additional ENICs for public sector employees, and commission services are all subject to local negotiation with providers. I want to move on to talking about public health, which is my particular interest as well. I agree with the honourable members on the importance of public health investment. In 2025-26, we are increasing funding through the Public Health Grant and the 100% retained business rate arrangements for local authorities in Greater Manchester to £3.858 billion. That's a 5.4% cash increase and 3% in real terms. It is a priority for this government to confirm future year allocations as early as possible, and we will be seeking to do that, and it is a priority of mine. We also talked a lot about social care. Madam Speaker, Louise Casey commands a great respect across parties, government and the NHS, and that's why she'll be leading the Independent Commission into Adult Social Care as part of our critical first steps towards delivering a national care service. She will begin her work in April and drawing on people who need care and their families, staff and politicians in the public, private and third sector to contribute and inform those recommendations on how we rebuild adult social care. I will very briefly.
Lady and welcome her to her place and congratulate her on her new role. In terms of building the National Care Service and the Casey review, will she reassure me and other members of the House that there will be a first phase report in 2026 which will inform the spending review and have action sooner than the 2028 final report?
I thank my honourable friend for her intervention, and I can confirm that, as has already been stated, those interim reports will take place with a view to informing spending reviews. I wanted to pick up the Lib Dem spokesman raised about the cross-party talks. My right honourable friend, the Secretary of State, wrote to colleagues from all of the UK-wide parties, inviting them to joint cross-party talks in February. Now, not everybody was able to take part in that. A significant number were not, and we think it's really important to have the wide range of views at these talks. So we have taken a decision to reschedule, but we will be making sure that those take place, and we are seeking to reorganise those talks at the earliest opportunity. The intention is very much to go ahead, I can confirm that. In terms of pharmacy, we're committed to look at how we can further expand the role of pharmacies and better utilise the clinical skills of pharmacists. And we've now resumed our consultation with Community Pharmacy England regarding the funding arrangements for 24-25 and 25-26. I'm unable to say any more on that until the consultation has finished. Wrapping up, Madam Deputy Speaker, we are undertaking the largest capital investment in our National Health Service since Labour was last in office. But if we are to deliver our promises to the British people, we must deliver faster improvement than even the last Labour government achieved. Investment and reform is what we promised before the election, and investment and reform is what we are delivering now. We will ensure the NHS is there for people when they need it. We will tackle the big killers like cancer and create a fairer Britain where everyone lives well for longer, while making sure every penny of taxpayer money is well spent. And I commend the estimates to the House.
I now call Sir Geoffrey Clifton-Brown to wind up.
Madam Deputy Speaker, thank you very much. I shall be very brief. Can I thank the Minister, the Honourable Member for West Lancashire, for a very comprehensive reply and congratulate her on her new role. And can I congratulate everybody who spoke in this debate today? There were some excellent speeches. Can I ask the Minister to thank her officials for appearing before my committee? That's very much appreciated. Can I thank particularly the members of my committee? It's a very hard-working committee producing 2 reports, major reports a week, particularly my deputy, the member of Sheffield South East. Just to very briefly sum up, as I said in my speech, productivity is the key to reform of the long-term reform of the NHS. Increasing funds at 4% real per year when the economy is only growing at 1%, long-term is unsustainable. So something has to be reformed in the health service. So can I ask, as I did in my speech, the Minister to consider producing a productivity plan? So without all the arguments with the ONS and everybody else, we can actually see what the really best estimate of the DHSC is for productivity gains over, say, the next 5 or 10 years. We can then start to see how these goals are going to be met. I do think within that productivity, modern technology, modern digital technology is really important. And the Minister skated over one word, which I'm really concerned about, and that is cyber. We had a wake-up call on WannaCry 2 or 3 years ago. The NHS contains some very personal, important data. It is vital, therefore, that we move towards modern machines which are able to withstand cyber attacks better than some of the analogue equipment there is in the NHS at the moment. So with those very few remarks, it's been a great debate, and I'm sure the Minister will have plenty to think about.
Order, order. The question necessary to dispose of the motion stands over until 7 p.m. under Standing Order number 54. I'll give the front benches a few moments just to swap over.